So now going to the laboratory aspects of hepatitis. So the points of discussion will be based on liver biopsy, viral serology, viral PCR, and liver function tests, just a mention on that. So starting with liver biopsy, because that's the topic of interest for pathologists. The adequacy criteria for liver biopsy, we require a minimum of 1 centimeter long biopsy with at least 6 portal tracts. This is the minimum. But to give a good assessment of the disease, at least a 2 centimeter long biopsy, 1.4 mm wide, with 11 portal tracts would be considered ideal, so that we could stage the fibrosis and necroinflammatory activity in the liver. So what is the role of liver biopsy in hepatitis? Mostly we don't get any biopsies for acute hepatitis unless and until there is a clinical dilemma, whether it's an acute viral hepatitis or autoimmune or drug induced. So most often we get liver biopsies for chronic hepatitis. So it's a prognostic tool. It helps to assess the severity of the disease. It provides information about liver disease progression by the grading of necroinflammatory activity and staging of fibrosis. It helps clinicians in management and therapeutic decisions. It helps to monitor response to therapy. Also helps in excluding other diseases like autoimmune hepatitis or steatosis. And of course, as we just heard, it helps to rule out hepatocellular carcinoma. So this is just a histological picture of acute viral hepatitis. Most often we don't get a liver biopsy for the same, but what we are seeing here is a lobular disarray. The lobular pattern of arrangement of liver parenchyma is lost because of the hepatocyte necrosis and mononuclear inflammatory infiltrate. And there is a Kupffer cell hyperplasia and hypertrophy and hepatocellular regeneration. So this is an acute viral hepatitis, the differential diagnosis of which would be a drug-induced liver injury, where the pattern will be slightly different, and autoimmune hepatitis. So these are close differentials in acute hepatitis. So coming to the chronic viral hepatitis, the hallmarks of chronic viral hepatitis in a liver biopsy is based on portal inflammation, interphase or periportal hepatitis, varying degrees of parenchymal inflammation and necrosis, and fibrosis. So we look for these 4 things in a liver biopsy when we get a biopsy for chronic viral hepatitis. So this is a picture which shows the chronic portal inflammation. In chronic viral hepatitis, this is from hepatitis C. There's a dense mononuclear portal inflammation. There's a lymphoid aggregate with even germinal center formation. The portal tract itself is not visible clearly because of the dense mononuclear inflammatory infiltrate. Then coming to the interphase hepatitis. So interphase hepatitis refers to the limiting plate between the portal tract and the hepatocytes. Usually it's a distinct zone, but here because of the inflammation spilling over into the hepatocytes, the limiting plate is not clearly visible. So that is called as interphase hepatitis. So it has 2 components. One is the inflammatory infiltrate, and the other one is the hepatocytes, which are showing ballooning degeneration because of the inflammation. So we look for interphase hepatitis. The third thing we look for is parenchymal inflammation and necrosis. So in the left side picture, we see that the mononuclear cells are seen forming clusters within the hepatocytes, leading to lysis of the hepatocytes and necrosis. And on the right side, we can see the presence of an acidophil body because of hepatocyte necrosis. And lastly, fibrosis. This is a Mason's trichrome stain, which has caused portal fibrous expansion seen in a patient with chronic hepatitis C. Apart from fibrous expansion, there are few fibrous bands which are also being seen, portoportal bands. So how do we, what mechanism do we use to give the clinicians a certain idea as to what kind of necroinflammatory activity is going on in the liver? So for that, we use the Ishaq's modified hepatitis activity scoring, which is based on those parameters which we just discussed: the portal inflammation, the interphase hepatitis, the presence of confluent necrosis, and focal lytic necrosis, apoptosis, and focal inflammation. So these are graded. For portal inflammation, we have 4 points. For interphase hepatitis, 4, confluent necrosis, 6, and spotty necrosis, 4. So total of 18 points. So based on what we see in the histopathological aspect of the biopsy, we give a grading out of 18. And there's a separate scoring for fibrosis, which is scored from 0 to 6 based on whether there is just fibrous expansion of portal tracts, or there are portoportal bridging, portocentral bridging, or there is incomplete nodule formation or complete nodule formation. So whenever we get a biopsy for chronic hepatitis, we give the Ishaq's modified HAI scoring, which gives the clinician a good understanding of how the patient is responding to therapy and how they should take forward the patient with the therapy. So this is the Ishaq scoring again for piecemeal necrosis, confluent necrosis, apoptosis, and portal inflammation. So this is a Mason's trichrome stain, which is showing nodule formation because of dense fibrous bands. And this is a reticulin stain again, which helps us to delineate those nodules clearly. Lastly, a few other points which help in hepatitis B. In chronic hepatitis B, there can be ground glass appearance of hepatocytes because of the presence of hepatitis B surface antigen. And few points which favor hepatitis C are the presence of macrovesicular hepatic steatosis, and also mononuclear inflammatory infiltrate, which is dense, especially lymphoid aggregates, which are seen in hepatitis C. And of course, liver biopsy plays an important role in confirming hepatocellular carcinoma. So this is a histopathological picture of a background cirrhotic liver. As we can see, the hepatocellular carcinoma, which has been marked with the black dotted line. So that was the importance of liver biopsy as far as hepatitis is concerned. So coming next to viral serology, I think we have heard in great detail from ma'am. So we will just be going through a few important points. So this is the structure of hepatitis B virus. So it has a surface antigen, which is hepatitis B surface antigen. So this is a very important antigen because antibodies to the surface antigen, that is anti-HBsAg, are protective. So that is the vaccination protocol also. We give when we develop antibodies to the surface antigen and we have good anti-HBs titers, then we are said to be protected against the virus. And then we have the core antigen. The core antigen is one which is completely hiding and it is not at all present in the blood. So it is only the anti-HBc which we can detect in the blood, in the serum. And we have the envelope antigen, which, as ma'am has already said, is a marker of viral activity and replication. And of course, we can detect the DNA. So the first marker to appear in the serum when a patient contracts infection is going to be HBsAg. The hepatitis B surface antigen is the first one to be detected even before the LFT raises. And then we also have the hepatitis B E antigen, the envelope antigen, which can be detected. Now, since the HBC, the core antigen, is not detectable, the IgM anti-HBC starts rising almost in par with the HBsAg. So a patient who has HBsAg positive and anti-HBC IgM positive is in the acute infected phase. And once the patient starts producing anti-HBs, he is going to have neutralization of the HBsAg. Now, there is a window period here where the patient is actually HBsAg positive and he's also secreting anti-HBs. So the neutralization is occurring. And at this window period, we won't be able to detect either HBsAg or anti-HBsAg in the serum because the antibodies are just neutralizing the antigens. And in this period, to detect the patient with infectivity, we either need to do an anti-HBc, which may be positive, or sometimes we have to look for the viral DNA. And of course, as we saw, as the HBeAg, anti-HBeAg gets secreted, the HBeAg disappears from the blood. So this window period is an important period where the patient may have negative HBsAg, he may be negative for anti-HBs, but still he may be infective. So the seroprofile in hepatitis B, a susceptible patient will be negative for surface antigen, anti-HBs, and anti-HBc. A person who's vaccinated is going to be positive only for anti-HBs. If there has been past infection, then HBsAg is negative, but anti-HBs and anti-HBc are positive. In an acute infection, a patient is going to be positive for HBsAg antigen and anti-HBs is negative, whereas anti-HBc IgM is going to be positive. Whereas in chronic infection, HBsAg is positive, anti-HBs is negative, and anti-HBc IgG is going to be positive. So this is the seroprofile in hepatitis B. So these are some of our lab reports. We have an acute hepatitis profile where we do an anti-HAV IgM, anti-HEV, anti-HBC IgM, and HBsAg. And then we, via CLIA, we do HBsAg antigen. We also use a rapid screening test, immunochromatography for HBsAg, with results which can be available within an hour. Then the anti-HBs titers and the anti-HBC IgM, the HBe antigen, the anti-HBe. So those are the tests, all the battery of tests which are available in our lab, and we have a short turnaround time of 3 hours for most of the tests, some of which we run only once a week. So next, we are discussing about quantitative PCR for HBV DNA and HCV RNA. So there are two types of PCR, as we know. One is the qualitative, which is used to detect the presence or absence of a specific DNA product. Whereas quantitative real-time PCR allows both detection and quantification of the PCR. So quantification of viral load helps to make therapeutic decisions. So as we just heard from ma'am, the cutoff of 2000 international units being used for starting treatment. So the TAT for the turnaround time for PCR in our lab is 48 hours. And the sample we require is 4 ml of EDTA whole blood. So this is a HPV DNA quantitative PCR. It's a closed system. It's a NAT chip-based real-time PCR. And this is a quantitative PCR. And this is a HCV RNA quantitative PCR where we use Gene Expert. So lastly, the liver function tests, of course, as we all know, we have a turnaround time of 1 hour. And these are the parameters which we give. So that's it from the laboratory aspects of viral hepatitis. Thank you.
It was a nice session, as we could have seen from the question answer sessions. We have got a lot of questions, and all the questions have got really good answers, and more. I hope most of the queries has been solved. And even if any of the participant, if they have any future queries with respect to this webinar or any other webinar which has been presented on this platform, they can just mail it. We will forward it to our expert panel, and our expert panel and our presenters or our speakers will answer it by mail. So let me thank the speakers, Dr. Shubha Madam, for accepting this invitation and giving our audience about the insight with respect to the chronic liver hepatitis, and also with respect to the laboratory investigations and their usefulness. I am also thankful for all our participants for attending this webinar. And if they have any other queries, they can just forward to the email IDs so that we can forward it to our presenters and expert panel. They will answer the questions. And finally, let me thank to the management of Meenakshi Lab for giving us this platform so that we can share the knowledge from our expert panel, and which will reach to most of the clinicians or most of our referring doctors, where they can have the insight with respect to the newer advances in the medical field. So let me thank for all the participants, and let me thank to the speakers as well as to the management of Meenakshi Lab. Thank you.